I'm Pat Strollo. I'm a professor of medicine at the University of Pittsburgh. I've changed my role at the University of Pittsburgh over the years. I was recruited by Mark Sanders, who was the section head for our sleep and breathing team. And my intent was to spend 2 years at the University of Pittsburgh, and that was in 1993. I've been at the university for 30 years. And over that time, we've really grown our program. We've been able to write a training grant in sleep medicine, and we did that with my colleague, Dr. Chris O'Donnell and Dan Vicey, who continues to lead the T32 in sleep medicine. And the initial goal was to really train physician scientists to hopefully inform practice and research in the field of sleep medicine. And we've been fortunate. We were one of the first 8 programs in the country to have sleep T32s. And it's been an honor to be able to train so many people and have them continue to contribute to the field of sleep medicine. As a result of me being at the University of Pittsburgh, I've had lots of opportunities. I'm now the Vice Chair of Medicine for Veterans Affairs, and I serve as Chair of Medicine at the VA hospital, but I continue to do research and see patients at the university. And because of our strong relationship with the research community, it's afforded me some opportunities that I probably would have never have had before. So a number of years ago, in 2007, I was contacted by Ed Schuck, who unfortunately has passed away, but he was one of the original people who developed a home sleep app, home testing for sleep apnea. And it was the EdenTech device, and it was pre-digital. So it was actually recording signals and printing it out on paper. And the EdenTech device was one of the few devices that actually was able to provide home sleep testing well before other manufacturers got into the business, and it was the only thing that we could really use for research many, many years ago. But Ed had contacted me because he was on the board of this new company called Inspire, and he asked me if I would be interested in helping him with a study for a device that stimulates the upper airway. And it was fortunate that one of the people who I helped train in sleep medicine was Ryan Seuss, who was an ENT, and he was the first ENT that went through our sleep fellowship. And because he was fully trained in sleep medicine, it was a natural fit for Ryan and I to move forward with the Inspire program. And we performed the first implant in the United States for the upper airway stimulator that ultimately led to approval by FDA. And part of that was informed by the paper that I was fortunate to be involved in. I was the primary author of the STAR trial, which we still continue to publish data from. And it's really taken a lot of my research in a slightly different direction. So, one of the things that I always advise fellows is that, we always seem to focus on people in training the art of saying no, but sometimes there's value to the art of saying yes. And, that's one of the things that I was certainly glad that I said yes to, and it's really kind of made my career go in a slightly different path. So, previously I'd been more involved with diagnostic techniques and really focused on on PAP therapy, but this really got me into the space of alternative treatments to CPAP, which has really become a tool that many of us now use in the sleep field, and this technology is only getting better. So I think it's an area where there's plenty of room under the tent, and having more tools to treat our patients with sleep apnea is much better. So the other area that I've been fortunate to be involved in with the University of Pittsburgh, working with Mark Sanders, my original goal was to try to help understand a little bit more about how bilevel pressure can work and support people who have ventilatory insufficiency. And over the years, we've certainly become much more adept to being able to treat patients with ventilatory insufficiency. And part of my practice really incorporates pulmonary and sleep, and I take care of a number of patients with neuromuscular disease where we've been able to use positive pressure to help patients. And this has really been a gap area in pulmonary care, and in some respects also sleep medicine. But because we teach our sleep fellows about positive pressure, a lot of times the sleep fellows have an opportunity to learn a little bit more about positive pressure. And one of my trainees, John Coleman, now is at Northwestern University and is really considered to be an expert in this particular area, and I'm very proud of that legacy, that he was able to move on and really be a leader in this particular area. And we were just at the American Thoracic Society meeting where he led a course. So that's one of the things as a mentor you're always happy about. How I got involved in sleep medicine is kind of an interesting story. I was in the Air Force, and I was about to graduate from my training program in pulmonary and critical care, and was planning on going to California to run an ICU at David Grant Medical Center. And the director of our division chief, Dave Shank, said, well, I would like you to stay and run the sleep lab. And I said, that's fine, but I don't know that much about sleep. We had one rotation as pulmonary fellows, but I was in no way really prepared to run a sleep lab, and we didn't have a sleep lab. So I said, fine, just send me to Stanford for some courses, and I'll try and figure it out. And the Air Force was kind enough to provide me the support to go to Stanford, and I met Alex Chediak at that course, who was one of the presidents of the American Academy of Sleep Medicine, and learned from Dr. Gimino and other major contributors to the field, and it was very exciting. And that was a time when we were really scoring sleep with traditional old grass machines and paper recordings. And obviously the field has evolved, but that was exciting. It was new, and I brought that knowledge back to Wilford Hall, the major teaching hospital for the Air Force, and set up the first full-service sleep center in the Air Force. So I was fortunate to actually hire Larry Epstein as one of the faculty members in our pulmonary and sleep program, who also became a president of the American Academy of Sleep Medicine. But getting back to my time, even I think before Larry showed up, I went to my first sleep meeting in 1987. And that was a very interesting meeting because it was held in one room. It was in San Diego. And the big presentation for that meeting was by Mayor Krieger. And Mayor Krieger presented the data from the HE study. And the HE study demonstrated that you could treat people with CPAP as opposed to tracheostomy. And that was published in Chest. And the one takeaway from that study was that if you use CPAP, you had an incredible survival advantage, better than tracheostomy. The one conversation that I had with Mayor Krieger many years after that was that he submitted that study to the New England Journal. And the New England Journal immediately rejected it because the response was, well, this is an obscure problem and would be of little interest to the readership. Go figure. So that's probably something worth talking to Mayor about, because I think he still has the letter of rejection from the New England Journal. Christian was, an incredible teacher. He was a great observer, and he was someone who could really see things through a different lens. And as you know, he was someone who actually made the first operational definition of obstructive sleep apnea. And he was the one who, from my recollection, he described an apnea as stopping breathing for 10 seconds. And when you stop breathing for 10 seconds, you have a desaturation. Now, it may have been different if Christian was a well-trained athlete. He was a smoker. And at that time, I think in later years he stopped smoking. But if that's how the 10-second rule for sleep apnea evolved. And I also, at Stanford had the opportunity to work with Sharon Keenan, who, developed that course and really, ran it for many years, and it was very efficient. The other thing that was interesting about my journey in sleep medicine was that, we had what we called a rogue board in sleep medicine. And so everyone went to Columbus and took an oral exam and a written exam. We actually took the written exam first, and then we went to Columbus and took the oral exam. And that was really working with old stacks of GRAS polygraphs and questions asked about that. And it was run by Helmut Schmidt, who was an old head in the field. So that was quite an adventure. And it wasn't until a number of years later that the American Board of Internal Medicine took on sleep as a true subspecialty of medicine. And it was interesting how that evolved, because it was really a collaborative effort, and it did not necessarily only include people who trained in internal medicine and pulmonary, but it embraced the ability to have people certify in family practice and anesthesiology and ENT and surgery, other surgeries if they so chose, and pediatrics. So that was really transformational. The unintended consequence of the ABIM exam, though, was that now we needed to set up formal training programs. We needed to add an additional year to fellowship training, which prior to that, you could qualify to take the rogue board, by self-attestation. But now it was very formal, it was structured much like critical care, where critical care was a one-year exam, one-year training period in order to take the exam. And the unintended consequence was that we only really started to turn out about 150 or less new sleep doctors per year, and the number of sleep doctors started to drop. In 2008, when the first board exam was given, the American Board of Internal Medicine always allows people to grandfather in and take the board if they've been practicing in that area. And so we had a large increase in the number of certified sleep physicians, and they were primarily pulmonary people at that time. About 60% of the sleep physicians were trained in pulmonary, primarily because sleep apnea was a big part of what we did. It wasn't until later on that we really incorporated much more robust training and treatment for insomnia and hypersomnia and narcolepsy and circadian rhythm problems and restless legs in adult sleep medicine. So that was sort of an unintended consequence, but now, I think the Academy has realized that and been able to develop the AIR program, which one of my fellows has participated in this year, and will be moving on to faculty as one of our team. So I think that it's interesting how this evolves. I've also had the opportunity over the years to be able to work with the American Medical Association. I've been a delegate for the AMA House of Delegates, and it's been an interesting experience, and it's something that I didn't really have in my sights, but I thoroughly enjoyed. And occasionally we've had some big wins this past year. In particular, we were successful in getting the House of Delegates to support the SAVE standard time, and hopefully that will be a lever that the Academy can use to help Congress see that this would be an appropriate adjustment in our national legislature. I got involved in the AASM primarily because I wanted to learn more about sleep medicine, and it was really going to that first meeting in San Diego and seeing the excitement of a new field and doing something new. I trained as a pulmonary fellow doing applied physiology and doing animal experiments, really looking at high-frequency jet ventilation as a physiologic tool. But I realized that I really enjoyed applied physiology, and there was a real opportunity to be able to use applied physiology during the sleep period. And the AASM was a great fit to help me move that interest along. I was encouraged by people that I worked with, Mark Sanders, who was my friend and mentor for many years at the University of Pittsburgh, and the inventor of BiPAP, was involved in the Academy at that time and really helped me get introduced to the Academy. David White, who I have known for many, many years, encouraged me to seek leadership in the American Academy of Sleep Medicine. And one of the things he had mentioned to me was, well, the one thing is when you're on the board, you really know exactly what's going on, at the Academy. That's not true in other professional societies. And some of our pulmonary societies are so large that it's hard to have an impact. So David White's been a friend and mentor for many years, and he also encouraged me to be the sleep person on the American Board of Internal Medicine pulmonary disease section, which I did participate in. So, and this work, has kind of just evolved over time. I met Larry Epstein, who we worked together in our idle youth in the Air Force when we were both Air Force officers. And it was clear that both Larry and I had a passion for education. And we served on the education committee at the American Academy of Sleep Medicine. And that was, I think, the first taste of interacting, with the society on a little different level rather than a participant, but really helping shape some of the future. And that led to an opportunity for me to chair the National Sleep Medicine course. And I took over the National Sleep Medicine course from Catesby Ware, who had run the course for many years. And one of the things that I had vowed when I took over that course was I didn't think that lectures on penile tumescence were the future of the world of sleep medicine. And I did adjust the course content to get rid of talks on nocturnal penile tumescence. For history's sake, it's probably an interesting thing to include, but I led the National Sleep Medicine course as the first pulmonary sleep person for a number of years until we changed the content and how that was delivered. When I finally arrived on the board, I think, working on the board, there were some remarkable people that I had the opportunity to interact with. And at that time, this was right around when home sleep testing was, a very hot topic. There was a lot of uncertainty whether doing home sleep testing would be the right path for evaluating and making decisions for initiating treatment for sleep apnea. And quite frankly, there was a little bit of pushback from the board. And I really worked politically to help put together an initiative that turned out to be the HOME-PAP trial, which was one of the large trials that the Academy funded to test home sleep testing with auto-titrating CPAP to in-lab diagnostic testing for sleep apnea, and then in-lab titrations. And Susan Redline won that grant. And the outcome of those data really showed that home sleep testing were as good and possibly slightly better than actually in-lab titrations. And I was very proud that I pushed for that. The other thing I pushed for at the board meeting was to establish a registry because I thought that was a need in our field. That was unsuccessful. But I think we're still talking about registries in our field right now. And I think that the thing was, at that time, it was very difficult to pay for registries. This was pre-electronic health record, and a lot of those data had to be collected and archived, using pen and paper, and that was quite, time consuming and it was expensive. The Society of Thoracic Surgery could do that because they had a bigger war chest. But I think now in our field, everything is electronic, and it's much easier to generate registries and archive registry patients, and use artificial intelligence to make some decisions. I don't think we've really exhausted all those capabilities. It's probably one of the reasons why when I moved to the VA for a lot of my administrative functions, I also chose to be the local site PI for the Million Veterans Project. So I'm hoping that the Million Veterans Project will allow us to be able to explore some key issues in sleep medicine. The journey to get the field recognized as an independent process was not exactly smooth sailing. The Academy really pushed to interact with the American Medical Association. That was my first brush with the American Medical Association when the AMA had a group for performance improvement, and we actually developed some metrics for practice improvement, and that kind of laid some of the groundwork for ACGME and ABIM to recognize the field. It was interesting, though, interacting in those early days with the AMA, because it was not uncommon that I would have someone at the Consortium for Performance Improvement come up to me and say, well, what is sleep medicine? And is that a real specialty? And, it was somewhat flabbergasted. And that was even after the ABIM had certified the field. So I think we had to make the case that this was, a legitimate field that took, some dedicated work in terms of clinical time, and also a body of research that really informed a population that was missing. In the past, prior to board exam for sleep certification, neurologists tinkered a little bit with hypersomnia, and psychiatrists and psychologists did a little bit in the insomnia space, and pulmonologists worked in the sleep apnea space because, back in the early days, tracheostomy was one of the key interventions that we could do for sleep apnea, which was rather crude. But understanding that, we were stronger as a group was very important. And, when I look back from that first sleep meeting that I went to, where there were probably 200 people in the room, to now in 2023, we have 4,000 people attending the meeting, and from all types of specialties, and actually getting people from all over the world to come and hear about the latest advances in sleep medicine. I know that one of the things that I did help early on was with the Coleman II study, which the Coleman II study was an interesting study that really demonstrated that people who come to sleep clinics frequently have more than one sleep problem. And it's not all sleep apnea. And I've used that in lectures over the years. It's now dated information, but it really reinforces that you cannot have your blinders on when you take care of a patient with sleep disorder. Even sleep apnea, now there's this conversation about comorbid sleep apnea and insomnia, and there's a lot of work in this space. We know that many patients have residual daytime sleepiness, and that's as important to the patient as treating their sleep apnea. Sometimes the sleep apnea can be effectively treated, and they still require additional treatment. And what I've told the fellows over the years is that what defines a sleep doctor is probably not writing a prescription for CPAP, but being comfortable managing stimulants and hypnotics in the patients that we take care of. Well, I think there's a number of accomplishments of the Academy. I think codifying the field was obviously, a very important thing. Creating a home for sleep medicine. So one of the things when I was on the board, I was involved in visiting sites and picking a site for the Academy, which we decided was going to be in Chicago. And Chicago was a good choice because there are many other major medical societies, including the AMA in Chicago. Also, it's one flight for almost everyone in the United States to get to, which made it convenient. One of the things that I do remember, I was president of the Academy when we had the groundbreaking for the site in Darien, which is where the Academy is housed. And because I was the president, I got the opportunity to stick the shovel in the ground for the picture. And right as we were about to take the picture, Bill Dement stood in front of me. And so if you look at the picture, I'm sort of half seen, and it's a glamour shot for Bill, which is probably appropriate. I've worked with a lot of great leaders at the Academy. Dan Bicey was president of the American Academy of Sleep Medicine prior to me rotating on the board, and he's been a close colleague for many years. We've been on numerous grants together. I mentioned that we've been involved with the T32 in sleep medicine for many years at the University of Pittsburgh. David White was obviously someone who really encouraged me to be involved in the Academy as opposed to just being siloed in some of the pulmonary societies. And I think that was great advice. I had the opportunity to work with Larry Epstein, who, was a little junior to me, but was a president before me at the Academy. And, that's been a friendship that we've maintained for many, many years, and I'm very proud of that. Alex Chediak, who's also was a president of the Academy prior to me. He and I, again, we've interacted since I was in training. We went to Stanford for training in sleep medicine together, many years ago. And we've worked on the AMA together, and I've always enjoyed our discussions. Unfortunately, this year, Alex is stepping down as being a delegate in the Academy, for the Academy at the AMA. So I'll certainly miss, those spirited discussions that we had about sleep medicine, private practice versus academics, and what the balance is. Safwan Bader, who has been a great leader, is someone that I was fortunate to help get on the board, and I think he's done a wonderful job at the Academy. We continue to collaborate. We're both chairs of medicine, and we frequently share some of our problems via the phone on occasion, and we currently have a grant that we're doing together in Merit, looking at comorbid insomnia and COPD and the impact on pulmonary rehabilitation. Jerry Barrett was a larger-than-life character for the as the executive director of the Academy, and he really helped kind of form the first strategic plan for the Academy. He was instrumental in moving the Academy from Rochester, Minnesota, to Chicago, which I think was a smart move because, again, it was an area where you could interact with a lot of other professional societies. It was easier to get to than Rochester. He built the Academy's staff and provided support. He had the foresight to really look at different income streams for the Academy, which served us very well for many years. He was instrumental in moving forward with accreditation of sleep centers, which on one hand was really helpful in terms of maintaining quality in a new field, and on the other hand, it did help support another income stream. He also was very supportive of education, and many of us worked on the education committee and helped advance the field. Developing slide sets. When we still had slide sets, right? The other leader in the Academy that's been a long-term friend and collaborator is Cleet Kushida, who was on the board with me. He was actually the president prior to my taking over, being president of the American Academy of Sleep Medicine. And Cleet and I have maintained a close relationship over the years, and we still continue to collaborate and work together in symposiums, both in the United States and internationally. I think some of our debate in the Academy has been, should we be U.S.-centric or should we embrace the world community of sleep medicine? And there were some spirited discussions regarding whether it was money well spent to have the Academy support the World Sleep Society. This is somewhat similar to the discussion we're having in the United States right now regarding the U.S. supporting NATO, where the U.S. tends to provide most of the economic support for NATO, that was a very similar discussion with World Sleep. We tended to have a significant contribution, and there was a lot of discussion around the board table whether this was a good investment or a bad investment. I actually sided on the fact that it was a good investment for the field. This has been an incredible ride over the past 30 plus years. I've been fortunate that I've been able to meet and interact with a lot of really smart and dedicated people in this field. I think overall, the field is in good position to continue to grow and really provide patients with, outstanding care. So I think the future is bright. The AASM is the professional home for both clinical sleep medicine and advocacy for sleep medicine and promoting research, new innovations through research.